Good evening, dear students. Welcome to you from Sri Rama Hospital, Jagaipet. In yesterday's class, we learnt about the carcinoma of the rectum, the clinical manifestations, the investigations, and the differential diagnosis. Now let us complete the topic of carcinoma of the rectum. That is the treatment of the carcinoma of the rectum. So the treatment of the carcinoma of the rectum is just like the treatment of carcinoma of the colon. Already we have studied about the management of carcinoma of the colon, as the rectum also is part of colon, but because it is anatomically in a different location, because of its different relations, we are studying it as separate, apart from colon cancer. But the principles of management of rectal cancer are same as that of principles of management of colon cancer. So preoperative assessment, evaluation of the TNM stage. So before surgery, you must assess two things for any cancer patient, not only rectal cancer, any cancer. Number one, what is the stage of disease? Is it operable or inoperable? Already we have discussed operable and inoperable meaning. Then you have to assess the fitness of the patient, because most of the oncological procedures, they put a lot of metabolic stress on the patient. Unless their vital organs and systems are up to the normal level, they will not be able to tolerate the surgical procedure. So you have to evaluate the operability and you have to evaluate the fitness of the patient. So how to evaluate the operability? By evaluation of the TNM staging. That means tumor, lymph nodes, and metastasis. So treatment depends upon the stage of the disease and fitness of the patient. For stage 1 disease, that means T1 and T2 lesions, a high-risk patient. High-risk patient means a patient who is unfit for a major surgical resection. For those patients, what you do is you go for transanal excision with or without neoadjuvant or adjuvant chemoradiation. I hope you understood these words. Neoadjuvant means preoperative administration of chemoradiation. That means chemotherapy and radiation combined. By this, what will happen? There will be downstaging and downgrading of the tumor. Then you can operate upon the patient through a operating telescope passed through the anus. So through the anus, the scope is passed and the tumor is excised. This is for stage T1 and T2 lesions. That means the tumor which is confined to the mucosa and submucosa. Where patient is low risk, that means it has no risk as far as metabolic and vital systems are concerned, you go for the radical surgery. Stage 2 patients, that means T3, T4, that means muscular involvement and serosal involvement or adjacent organ involvement, and stage 3, NET, N1 to 3. That means if lymph nodal metastasis is present, then you have to give neoadjuvant chemoradiation. That means preoperative, that means for about 3 to 4 weeks before surgery, you give chemotherapy as well as radiation to downstage and downgrade the tumor. Then you go for radical resection. For stage 4 disease, the patient has no symptoms. That means symptoms means bleeding per rectum, pain during defecation, or mass in the rectum causing constipation or altered bowel habits. Then you give chemotherapy, and resection is if growth is resectable or if single liver metastasis is seen. For symptomatic patients who are stage 4, that means wherever there is metastasis is there, for those cases, you give palliative measures. So in gist, this is the treatment protocol you follow for the patient with carcinoma of the rectum. So for stage 1, high-risk patients, transanal excision with or without chemoradiotherapy, either neoadjuvant or adjuvant. For well-fit patient, radical surgery. What is radical surgery? I will tell you in the next slide. For stage 2 and stage 3, give neoadjuvant chemoradiation so that you will downstage the tumor. Then you operate by radical surgery. For stage 4 disease, that means where metastasis is positive, if single metastasis in the liver is there, then you go ahead with radical surgery plus liver resection. If the patient is having symptomatic problems like constipation, but it is inoperable because it has fixed to the surrounding structures, there are widespread metastasis, that means M+. Then what you do, you just relieve the constipation by doing colostomy. That is palliative operation. So this is the protocol you follow for cancer rectal treatment. Preoperative preparation, same as for large bowel surgery. That means you give antibiotics for about 5 days. You give only liquid diet for 2 days, and you give Picolax. That is osmotic diuretic which flushes the colon the day before surgery. 2 days before surgery, you give Picolax to purge the colon and to wash the colon. Principles of radical surgery. What is the radical surgery principle? You remove the tumor. Wherever you do surgery for cancer, what you do, you remove the tumor-bearing organ along with its lymphatic field, that means lymphatic vessels and lymph nodes. So the tumor-bearing organ, the lymphatics, and the nearby lymph nodes. All these things are removed en masse. That is the principle of radical surgery for any tumor. For cancer rectum, you have to remove the rectum plus the lymphatic field. So what is the lymphatic field? The lymphatics, we have seen in the previous class that the lymphatics pass in an upward direction. Lower side, they do not pass more than 1 centimeter. So most of the lymph flow is only in an upward direction. If you raise a question why it doesn't go downwards, there is no answer for that. That it has been observed that the carcinoma of the rectum spreads by lymphatics in an upward direction. That means you have to remove all the lymphatics in the upward direction up to the inferior mesenteric artery pedicle. Lower one, you just go below 1 centimeter or 1.5 centimeters below is adequate. And these lymphatics, they pass in the areolar tissue that is there around the rectum. And that areolar tissue is called the mesorectum. So what you have to do, you have to remove the rectum along with all the areolar tissue that is there around the rectum. So you have to clear all the tissue that is there surrounding the rectum, not only the rectum, the surrounding areolar tissue must also be enclosed in the resection. And this resection must go in an upward direction. The lymphatic field must be there up to the inferior mesenteric artery. That means we have seen 3 groups of lymph nodes. Around the rectum, one first group, those are called the pericolic lymph nodes. Then along the blood vessels, those are called the intermediate group of lymph nodes. Then along the origin of, at the origin of inferior mesenteric artery, they are called the central group of lymph nodes. So these 3 groups of lymph nodes has to be removed. So you have to include the mesentery of the sigmoid colon up to the inferior mesenteric artery. And the rectum has to be removed completely, and 1 centimeter below the tumor, up to that you have to excise. So that is the principle of radical surgery. To remove the primary tumor, so the principle is to remove the primary tumor along with its lymphovascular supply. That is excision of the rectum together with the mesorectum and associated lymph nodes. So all these things has to be removed. And the lymph node spread occurs proximally. The proximal extent of the resection is up to the sigmoid colon. High proximal ligation of the inferior mesenteric lymphovascular pedicle to include N3 nodes. N3 nodes means the central nodes. And the distal spread is not present. Rectum is excised at 2 centimeters below the margin of the growth. Okay, this is the levator trine muscle. This is the rectum. Now, if the rectum can be divided into 3 parts, 1/3, 1/3, 1/3, upper 1/3, middle 1/3, and lower 1/3. So, if the tumor is there in the upper 1/3, that means what you can do? You can remove the rectum 2 centimeters below that. That means roughly it includes the middle 1/3. So you have to cut the middle 1/3, remove middle 1/3 of the rectum, upper 1/3 of the rectum, and sigmoid colon. You have to ligate the inferior mesenteric artery and remove all the peritoneum connected to the rectum and sigmoid colon. So that is for upper 1/3 tumors. Then what you do, once you remove this one, lower 1/3 rectum is remaining. So bring the descending colon and anastomosis to the rectum. That means you are doing colorectal anastomosis. So for upper 1/3 tumors, this is the radical surgery. For middle 1/3 tumors, okay, you come 2 centimeters below the growth and transect it. That means roughly you have to include the lower 1/3 of the rectum also has to be removed. Okay, so lower 1/3 of the rectum is removed. That means lower 1/3, middle 1/3, upper 1/3 of the rectum and sigmoid along with the mesentery of the sigmoid up to the inferior mesenteric artery is removed. Now what you do? You anastomose the descending colon to the anal canal directly. So you anastomose the descending colon to the anal canal. That is for middle 1/3 tumors. If the tumor is in the lower 1/3, you have to come 2 centimeters below the growth. So when you are coming for 2 centimeters below the growth means you have to remove the levator trine also. You have to remove the part of the anal canal also. So when you remove the part of the anal canal and remove the levator trine muscle, there is no sphincteric mechanism. That is why even if you do anastomosis of the colon to the remnant of the anal canal, that won't do the function. That will be a completely incontinent anus. So patient will be dribbling fecal matter from perineum. So in that case, what you do, you remove the whole rectum and anal canal and you end up with colostomy. Take the descending colon and keep it as colostomy outside. So for colon surgery, for the rectal surgery, the type of radical surgery depends upon the site of the tumor. For upper 1/3, radical excision followed by colorectal anastomosis. For the middle one-third lesions, you do radical excision of the rectum followed by coloanal anastomosis. For the lower one-third rectal tumors, you cannot do the anastomosis to the stump of anus. That is why what you do is you do colostomy and remove the whole of the sigmoid, rectum and anal canal. So this is the principle. I hope this is clear to you. Now we'll go to the principles. The anorectal ring is at 3 centimeters from analwards. Hence, growths above 5 to 6 centimeters from analwards can be removed and continuity can be established. So this anorectal ring or levator muscle is at 3 centimeters from analwards. So you add 2 centimeters for that. That means it comes to 5 centimeters. So roughly, tumors which are situated about 5 centimeters above the anal verge can be removed and restoration can be done. The growths below 5 centimeters from anal verge and anaplastic growths need complete excision of the rectum and anal canal. In the presence of a solitary liver metastasis, a radical excision can be done along with surgery of metastasis, as rectal cancer is slow growing like colon cancer. Already we have emphasized this fact in liver topic as well as in colon topic. So types of radical surgical treatment. There are 2 types of radical surgical treatment. Number 1, sphincter saving operation. That means you are saving the anal sphincters and you are establishing normal continuity of the fecal matter. This is called sphincter saving operation, also called as the anterior resection. So for which tumors you do sphincter saving operation? For tumors other than anaplastic. The tumor should not be anaplastic. If the tumor is anaplastic, it is ill-differentiated, then if you do this one, there will be more lower spread will be there for the tumors because it is anaplastic. So the anal canal also will be involved later by recurrence of the growth. So in those cases, you go for a complete removal of the rectum and anal canal. If the tumor is not anaplastic, if they are there present in the upper 2/3 of the rectum, you can go for sphincter saving operation. Of course, for this one, you need not bother. This what this means is the introduction of stapling gun has enabled even the lower third tumors. The tumors which are situated 2 centimeters above the anorectal ring can to be treated by a sphincter saving procedure. Whatever it is, the tumor must be 2 centimeters above the anorectal ring. So if the tumor is at 2 centimeters above the anorectal ring, means you can remove up to the anorectal ring and do the anastomosis to the anal canal directly. So this anastomosis to the anal canal can be done only with the help of a stapler. So first procedure is the sphincter saving operation, which is done for the upper 2/3 tumors. The second procedure is the abdominoperineal excision of the rectum with a permanent colostomy. That means complete excision of the rectum and anal canal. So anal canal is removed from perineum and rectum is removed from abdomen. So surgeon first has to do the abdominal dissection, separate the rectum, sigmoid, cut the sigmoid colon, put the descending colostomy. Then he has to come to the perineum and then you have to operate upon the perineum to remove the anal canal. So once he cuts around all the anal canal sphincters, so once he cuts the levator muscle, then automatically the whole rectum which was separated earlier in abdominal dissection can be pulled out through the perineum. So the surgeon is performing surgery by 2 approaches, abdominal approach and later perineal approach. So this operation is called the abdominoperineal resection of anorectum. So for this, what the patient will have, ultimately the patient will be landing with permanent colostomy. So this is done for lower third tumors of rectum without lower margin clearance of 2 centimeters. And of course for all anaplastic tumors, because there is high chance of local recurrence in those tumors. Wherever the tumor is there, you do resection of rectum and anal canal. So the perineal approach is done by keeping the patient in a lithotomy position. So the surgeon comes to the perineum and he makes an incision around the anus, including sphincters. Then he cuts around the anal sphincters, separates the anal canal from posteriorly from the sacrum and coccyx, anteriorly from the prostate and seminal vesicles. So there are two fasciae for the anal canal, in front and back. The back is the presacral fascia, the anterior is the Denon-Villiers fascia. So the Denon-Villiers fascia is cut posteriorly, anterior to the presacral fascia, dissection is made. And laterally, the levator muscles are cut. So once the levator muscles are cut means the surgeon is in the pelvis. So already the abdominal dissection has done, and so the rectum has been separated up to the levator muscle. So the lower part of the levator muscle is cut from the below. So the whole specimen is brought out from the perineum. The anterior section, this is sphincter saving operation. There are two methods you can do by open surgery or by laparoscopic procedure. Excision of the rectum along with the growth as mentioned in the principles of radical surgery. Restoration of continuity by direct end-to-end anastomosis manually or by stapling. Upper two-thirds tumors are managed by high anterior resection. High anterior resection means upper two-thirds are removed. Upper two-thirds of the rectum are removed, and colorectal anastomosis. You can see this is the colon and the remnant of the rectum. So colorectal anastomosis is done. The lower one-third tumors are managed by low anterior section, that means by doing colo-anal pouch anastomosis. So for lower one-third tumors means if there is lower border 2 centimeters clearance is there. If 2 centimeter clearance is not there, they should go for total anal and rectal excision. So this is the sphincter saving operation where you remove the sigmoid, rectum, upper two-thirds with the mesentery having the bowels, so having the vessels up to the origin of the inferior mesenteric artery. Abdominoperineal resection. That means this is excision of the rectum with anal canal. Indications: lower marginal tumors within 2 centimeters from the anorectal ring. Anaplastic tumors. The pelvic colon is brought out as terminal pelvic colostomy after excision of the rectum and anal canal. So you remove here the sigmoid, the rectum, and the anal canal, and including the mesentery up to the inferior mesenteric artery. So patient is left with a colostomy. Methods of operation: synchronous abdominoperineal resection. So here the surgeon is doing surgery on the abdominal side and perineal side. So if two surgeons are present to do the procedure, one surgeon can do from the abdominal side, the other surgeon can sit in the perineal side, and both can do, and both of course will meet at the pelvic diaphragm. So this is called the synchronous abdominoperineal resection. So two teams perform the procedure simultaneously. Then other procedure, the abdominoperineal resection, where only one surgeon performs first the abdominal procedure, that is rectal dissection and fashioning of the colostomy. Then he comes to the perineum and does the perineal dissection. and remove the total specimen out. This is called the abdominoperineal resection. Perineoabdominal operation. That means the surgeon first performs the perineal operation. That means separates the anal canal and cuts the levator muscle. Then he goes to the abdominal side, and then he operates the abdominal side and separates the rectum and removes the specimen from above and performs the colostomy. The colostomy is done for the descending colon. The end of the descending colon, that is done as colostomy. Because here the part that is involved is the rectum, but we are removing sigmoid colon also. Why? Tell me. We are removing sigmoid colon also. Why do we remove sigmoid colon? Because, yes, good. Because the lymphatics of the rectum drain in the upward direction. So in an upward direction, as much of organ as possible has to be resected. That is why the sigmoid colon also is removed. And the sigmoid colon is being removed, so we do only the colostomy. So if the pelvic colostomy was mentioned, means it is by mistake it was mentioned, I will correct it. Complication of this procedure: injury to the autonomic nerves, that is pelvic plexus formed by fusion of hypogastric nerves with nervi urgenti during posterior dissection, causing bladder and sexual dysfunction. More extensive radical operations: when growth has spread to the contiguous organs, the radical operation is extended to remove these structures also. That means if the rectal growth has involved the uterus or the vagina, in males if it is involved the prostate or the urinary bladder, so those organs are also included in the resection. In the male, if bladder is involved, cystectomy and resection of the rectum is done. In female, hysterectomy plus excision of the rectum is done. If the bladder base is involved, then a procedure called pelvic exenteration is done. In pelvic exenteration, all the pelvic organs together with interiliac and obturator group of lymph nodes is done, and urinary diversion is done. That means the bladder is removed, the rectum is removed, the urethra is removed, the prostate is removed, and the ureters are placed onto the skin as ureterostomy. So this is called the pelvic exenteration. So when the growth has involved the bladder base, but lymph nodes metastasis is not there, and widespread metastasis, disseminated metastasis is not there, then you can do complete local excision of the pelvic organs. Palliative treatment: surgery and radiotherapy depending upon the symptoms of the patient, and chemotherapy. For obstetric cases, you can go for endoscopic stenting. The surgery is transanal excision, laser destruction. So what is the problem with the rectal cancer? This is done only for inoperable cases where tumor has widely disseminated, where you cannot, even radical surgery, even if it is done, is of no benefit to the patient. So in those patients, what you do, you just remove the tumor mass so that it is not obstructing. So the main problem of the patient is constipation because of the obstructing growth. So what you do, pass an endoscope through the anus and remove as much of tumor as possible. Or with the help of laser, you burn out the tumor so that lumen will be established. Or if tumor is higher above, you can remove the tumor and do the colostomy. That's called the Hartmann's operation. Already we have discussed that. Or you can go for stenting operation. Now we have expandable metallic stents are available. So those expanding metal stents can be placed in the rectum. Now if the patient presents with acute intestinal obstruction, what you do? First you do pelvic colostomy or Hartmann's resection or endoscopic stenting. obstruction is relieved. Once the patient condition improves, the appropriate radical surgery is done if the tumor is operable. Radiotherapy with modern techniques, some adenocarcinomas now respond to radiotherapy. Role of radiotherapy as adjuvant therapy, that means following surgery, you give radiation to prevent recurrences at the site of operation. If you give radiotherapy before surgery, that is to downgrade and downsize the T4, T3 tumors. This is called the neoadjuvant chemotherapy, radiotherapy. And radiotherapy also is given as palliation in inoperable tumors for treating the inoperable tumors. That means it shrinks the size of the tumor, so the obstruction is relieved and patients will pass normal stools for some time. And the radiation can be given by intracavity or interstitial radiation. Chemotherapy indications as adjuvant therapy in treatment of disseminated diseases. Drugs used are 5-fluorouracil, intraportal vein administration of 5-fluorouracil during and immediately after primary operation. Other drugs used are the adjuvant therapy along with 5-FU, that is systemic folinic acid, levamisole, and various other monoclonal antibodies to carcinoembryonic antigen. Of course, we have already discussed about the transanal endoscopic microsurgery for T1, T2 lesions. Prognosis of carcinoma of the rectum. Stage 1, 80 to 90% prognosis. Stage 2, 60 to 76%. Stage 3, 30 to 40%. Stage 4, only 4 to 7%. Carcinoembryonic antigen. This is a tumor marker for colon cancer. It is useful in monitoring the disease for recurrence and for evaluating the prognosis. Carcinoid tumor of the rectum. It is slow growing. Carcinoids more than 2 centimeters are malignant. Metastasis late. Treatment: local excision if less than 2 centimeters. Resection of the rectum if the growth is malignant. Summary of management of carcinoma of the rectum. So patient's presentation is as altered bowel habits, mucus and blood per rectum. So these are the main symptoms. You do digital rectal examination. This is also called the per rectal examination. Proctoscopy. If they are not giving any indication, because proctoscopy and per rectal examination can evaluate tumors that are there only in the lower 1/3 and upper 1/3 tumors. The finger cannot go into the upper 1/3 of the rectum. So upper 1/3 tumors cannot be evaluated by digital rectal examination and by proctoscopy. So in those cases, you do sigmoidoscopy, then take the biopsy. Once the biopsy is confirmed that it is adenocarcinoma of the rectum, then you stage the disease. Staging means already we said it's TNM. That is done with the help of endoluminal ultrasonography and CT scanning. Fitness evaluation. Sometimes patients may come to you with acute intestinal obstruction. When you do the per rectal examination, you will find tumor in the rectum. So you do the same abdominal examination, per rectal examination, X-ray abdomen, and you do pelvic colostomy or Hartmann's operation because it is acute intestinal obstruction. So you can't do radical surgery. So you are seeing for the first time that patient with carcinoma rectum presenting with intestinal obstruction. It is unprepared bowel. So you just relieve the obstruction by doing a colostomy or Hartmann's operation. Hartmann's operation can be done only for the upper 1/3 tumors. For middle 1/3, lower 1/3 cannot be done. So you just do the Hartmann's operation. If not possible, just do colostomy only. And 3 weeks later, you come for the staging and fitness evaluation. So we have 3 groups of patients. early patients, stage 2, stage 3 patients, and stage 4 patients. Stage 1 patient, assess the lower border. How far it is from anorectal ring. We have already seen if it is more than 2 centimeters above the anorectal ring, you can save the sphincters. If it is within 2 centimeters of the anorectal ring, you cannot save the sphincters. So that point you have noted. So now let us see. So 2 centimeters above anorectal ring, you go for sphincter saving operation. Within 2 centimeters of anorectal ring, you have to do abdominoperineal resection. For stage 2 and stage 3, what you do? You downstage the disease. By what? What do you do for stage 2 and stage 3 disease? Yes, very good. You go for yes, neoadjuvant therapy. So you do neoadjuvant chemoradiation, later treat them like stage 1 disease. Stage 4 means it is widespread metastasis. So only you give palliation. Palliation can be Hartmann's operation, laser destruction, transanal excision, radiotherapy, chemotherapy, or immunotherapy. So this is the summary of management of rectal cancer. I hope it is clear to you. Then carcinoma of the anal canal. Above the dentate line, it is visceral mucosa. Below the dentate line, the anal canal is lined by squamous, stratified squamous epithelium. So there are 2 types of cancers will develop. Above the dentate line, they are all the visceral type of cancers. Lymphoma, mucoepidermoid carcinoma. So below the dentate line, it is skin cancer. Squamous cell carcinoma, basal cell carcinoma, basaloid carcinoma, and melanoma. So the same cancer which occur in the skin, they occur in the anal canal. So this is the dentate line. Squamous cell carcinoma, it just presents like squamous cell carcinoma elsewhere on the skin. So it is the commonest tumor. You can see a proliferating mass. Etiology, anal warts in HIV cases. Following radiation given for pruritus ani. Sometimes, probably in the track of a long-standing fistula in ano and in Crohn's disease of the anal canal. Basal cell carcinoma, same as elsewhere. Basaloid carcinoma, this is also known as cloacogenic carcinoma and is form of non-keratinizing squamous carcinoma. It is highly malignant. It is not sensitive to radiation. Melanoma. It presents as a bluish black soft mass which is confused with a thrombotic pile. So we have seen perianal hematoma where there will be a clot in the perianal region. Similarly, there will be a blackish pigmented nodule in the anal canal. It spreads early by lymphatics and bloodstream. It is radio resistant and has a very poor prognosis. Then mucoepidermoid carcinoma, the tumor arises near the squamo-columnar junction, that is on the dentate line, and is of average malignancy and is radiosensitive. Lymphomas, this may rarely affect the anal region with widespread lymphomatous condition. Clinical features, incidence is 2% of colorectal cancers, age 50 to 60 years. Clinical presentation, rectal bleeding, mucous discharge, tenesmus, sensation of lump in the anus, a change in the bowel habit, mass in the inguinal region due to metastatic lymph nodes. Treatment of squamous carcinoma of the anal canal, tumors of anal verge, wide local excision with a margin of at least 2.5 centimeters, inguinal node involvement after excluding secondary infection by FNSC, block dissection of one or both groins is done. For large inflating lesions, abdominal perineal excision, removing the growth and perianal area widely. So if the tumor is involving the whole anal canal and sphincters are also involved, so wide excision means you have to remove the sphincters also. So when you are removing the sphincters, there is no question of continence. So in those cases, the best thing would be to do a colostomy and remove the total anorectum. If the inguinal nodes are involved, a radical dissection of the groins is also done. Radiotherapy alone can be used for selected small tumors by external beam, interstitial and intracavity techniques. Chemoradiotherapy is preferred initial therapy for all anal canal tumors. A combination of 5-FU and mitomycin is given for 1 week, followed by radiotherapy for 3 to 7 weeks. If there is a residual tumor, an abdominal perineal section is performed later. In frail patient with an advanced lesion, a colostomy is done. So this completes the topic on the disease of the rectum and anal canal. Any doubts, please? If you have no doubts, we will go to the topic of the disease of the appendix. Yes, wide excision means you have to remove 2 centimeters margin around the tumor. Okay, now we'll go ahead with the topic of the disease of the worm-form appendix. The anatomy of appendix. Appendix means literally it means annexum, a part attached to the main structure. The main structure is the alimentary tract, something is attached to it. So there is an annex to the colon. So this is the whole colon and this is the annex. So that is why it's called the annexum or appendix. In the lower animals, actually appendix is part of the dilated cecum. So this is the cecum and this continues down at the appendix. And it participates in digestion. In the herbivorous animals, it is well developed and it has an enzyme called cellulase. So with this cellulase enzyme, cecum and appendix cause digestion of the cellulose matter. That is why the animals can take a lot of leaves and they get energy from those leaves. But when we take leaves as food, so they are helpful only as a fiber and relieves the constipation. And bowel evacuation will be good with the large fiber foods. But we don't derive the carbohydrates from the cellulose. because we don't have that enzyme to break down the cellulose in the leaves. Of course, leaves can have other elements like other minerals and vitamins may be there. So they will be there available for us. But the energy source, carbohydrates, can be made from cellulose. So cellulose can be converted to glucose. That process is not there in human beings. It is there only in animals. I hope why it is not there in human beings, you can understand. Why? Because God has thought that if human beings were given the cellulase enzyme, then there will not be a single plant on the earth. So they eat away everything. So the whole earth will be seen as a bald brown structure. So no beauty will be there. So to preserve the beauty of the earth, God has taken away that cellulase enzyme from our intestines. That's why earth is still appearing little bit green, though not as green as when the God has created it. We have destroyed much of it. So without cellulase enzyme, it is like that. If it is, for example, with cellulase enzyme means it would have been in a different fashion. So appendix is a tubular structure and it opens into the posterior wall of the cecum just below the ileocecal valve. This is the ileocecal valve, and below that it has the opening. It's called the appendicular orifice. It has a mesentery. Through the mesentery, it gets the blood supply. The vessels are called the appendicular vessels. They supply the blood supply to the appendix, and you can see here the mesentery is there only for the proximal part of the appendix. The distal part of the appendix has no mesentery. Then what will happen to the blood vessel? The blood vessel runs in the mesoappendix. Where mesentery is not there, then it runs in the wall of the appendix. So this point you have to remember. Why? In acute appendicitis, there will be swollen appendix. When the appendix swells, it becomes turgid. So any blood vessel in this wall will undergo thrombosis because of its stretching and turgidness. So this terminal part where it has appendicular artery in its wall will suffer, becoming gangrenous. This part which is having the appendicular artery in its mesentery will not become gangrenous early, but the tip becomes gangrenous early in acute appendicitis because of this reason. Of course, there are peritoneal fossae around the cecum and appendix, that is inferior ileocecal fossa, retrocecal fossa, and superior ileocecal fossa. So sometimes appendix may be there in these fossae. So this is the mesoappendix with the appendicular artery. So this is the ileocolic artery. It divides into two branches, a cecal artery and an ileal artery. So from the ileocolic artery, this appendicular artery arises. It comes downwards, passes behind the ileum to enter the mesoappendix. And in the mesoappendix, it gives off branches to the appendix and ultimately runs in the wall of the appendix. This is called the intramural course of the appendicular artery. So this is the appendicular artery. In some individuals, there is an additional artery. Not only the appendicular artery, there is one more artery that comes from the posterior cecal artery. So that gives off a branch to the appendix. And this particular artery is called the accessory appendicular artery of Seshachalam. So Seshachalam was a professor of anatomy in SV Medical College about 40 years ago. So he has described this particular artery. So it goes by his name. And actually, in many of the medical colleges in Andhra Pradesh, this particular specimen will be there. cecum with appendix and an accessory artery of Seshachalam. Anatomy of the appendix. It is a vestigial diverticulum of the large bowel. The three longitudinal cords of the colon, that is tinea coli, they fuse to form a single sheet of longitudinal cord for the appendix. Just like for rectum, for appendix also, the three longitudinal tinea coli, they fuse together and form a uniform sheet. The appendix is situated in the right iliac fossa, arising from the base of the cecum. It has a mesentery transmitting appendicular artery, which is a branch of ileocolic artery. Its position is variable, but its base is constant at McBurney's point. It may be on the left side of the abdomen in situs inversus or non-rotation of the gut. What is situs inversus? All the organs which should be there on the right side, they will be on the left side. And what is the non-rotation of the gut? What is non-rotation of gut? And why appendix is on left side in non-rotation of gut? Already we have studied about this non-rotation of the gut. Okay, good. No anticlockwise rotation of the midgut during rotation. So it stays on the left side. Very good. So what is this McBurney's point? McBurney's point is situated like this. You take a point on the anterior superior iliac spine and a point at the umbilicus. You draw a line between the anterior superior spine and umbilicus. This line is called the spino-umbilical line. So at the junction of lateral 1/3 to medial 2/3, so at that junction, the base of the appendix rises. So this is the place where base of the appendix always stays. So its tip may be in various positions. It may be behind the cecum. It may be to the right of the cecum. It may be behind, so to the left of the cecum. It may be down towards the pelvis. So whatever may be the position of the appendix, its base is always constant at McBurney's point. Position of appendix in relation to cecum. At birth, appendix is short and broad at its junction with cecum. But later, the growth of the cecum makes it long and tubular. So initially, we have seen in the development of colon, during third stage of rotation of the midgut, the cecum is first initially at the subhepatic region. Then it grows and comes down into the right iliac fossa. So immediately at the time of birth, the cecum is not yet well developed. So what happens? It develops still more. That means it increases in size, thickness, and diameter, and it rotates. So by that, the appendix becomes long and tubular. Continued growth of cecum in childhood rotates the appendix into retrocecal and intraperitoneal position. In 25% of the cases, rotation of the appendix does not occur and results in pelvic, subcecal, or paracecal positions. Defect in second stage of rotation may result in non-rotation of the gut with appendix in left iliac fossa, not right iliac fossa. You can So defect in second stage of rotation may result in non-rotation of the gut with appendix in the left iliac fossa. Defect in third stage of rotation of midgut may result in subhepatic cecum and appendix. Just I am interrupting here. There is a question by one of our students, that is, why colostomy always anteriorly? I could not get your question. What is this? Colostomy anteriorly means? No, I could not understand your question. Acha, why colostomy is done on the anterabdominal wall? Very good. The reason is you can apply a appliance to collect the fecal matter. If the colon is done on the lateral wall or on the posterior wall, it is difficult to put a appliance there. So always, whenever you do colostomy, you should have a bag to collect the fecal matter, and that bag should be watertight. There should not be any leakage. So that's why it should be applied on a flat surface. If the surface is curved, like lateral abdominal wall, flank, so you cannot apply the appliance conveniently there without any spillage or leakage. So the colostomy is done always onto the anterior abdominal wall, never to the flank, never on the posterior side. I hope it is clear. Okay, let's come back here. These are the positions of the appendix. Normally, it is situated retrocecal in about 75% of the cases. And the other positions being pre-ileal, post-ileal, pelvic, subcecal, and paracecal. So these are the other positions of the appendix. So variations in position of appendix. This is left-sided cecum and appendix due to intestinal malrotation. In one of the previous classes, we learned that there may be non-rotation of the gut producing the cecum and ascending colon on the left side of the abdomen. So in that case, the appendix will be in the left iliac fossa. This is errors in the third stage of rotation, where cecum has not developed. So at the end of the second stage of rotation, the cecum will be occupying the subhepatic position like this. So then later it grows. As it's growing, it comes down like this into the right iliac fossa. Sometimes the third stage will not occur, resulting in the subhepatic cecum. Then in that case, the appendix also will be in the subhepatic region. Function of the appendix, it is a vestigial organ and the developmental purpose. So because there is no enzymatic digestion required, so the organ has become defunct and become small. But it has certain functions. It maintains the gut microflora, and because of its lymphoid patches, it has some immune function. The histology of the appendicular wall is same as that of the colon. In addition, it contains Kulczewski cells or the argentine cells, and these cells are responsible for congestion of the argentophenoma or the carcinoid tumor. Congenital anomalies, they are rare. There is agenesis and duplication. Inflammatory disorders, acute appendicitis. So this is the main disorder in the vermiform appendix. So you have to know about this. Though this organ is just little smaller than your index finger, but it occupies one whole chapter in our surgery textbook. Why? The reason is because of the high incidence of the acute appendicitis and presentation as the commonest acute surgical abdomen. FIDS coined the term acute appendicitis and advised early operation. Before FIDS, it was called as perityphlitis. Etiology: the exact cause why appendicitis or appendicular inflammation occurs is not known. The probable causes being diet. Decreased fiber in the diet with increased refined carbohydrates may be one of the causes attributed for acute appendicitis. And there is slightly a familial predisposition. Any obstruction of the appendix, obstruction of the appendix like intraluminal causes, a fecalith. Fecalith means inspissated fecal matter, calcium phosphate, bacteria, and epithelial debris. So all these things put together, it forms a stone-like in the appendicular lumen. So it can cause obstruction. Similarly, foreign bodies. If any foreign body by chance enters into the appendix, it can cause obstruction. Then worms like pinworms. Then intramural causes, stricture. Neoplastic lesions like carcinoids and carcinoma. Extramural causes like kinks. So all these things can cause obstruction to the appendix. Pathology: it is appendicular inflammation. FIDS has coined this word appendicitis. Before FIDS, I said it was called as perityphlitis. Why? Because before FIDS, if a patient comes with pain in the right iliac fossa, acute pain, vomitings, so the patients were treated by conservative measures, not by surgical measures. So on conservative measures, what will happen? After some time, there will be a thick mass will form. Because the appendicular inflammation resolves, all the bubbles there in the right iliac fossa, they mat together. Greater momentum comes and wraps around the appendix and forms a thick, tender mass. So surgeons thought that the whole process is occurring because there is inflammation around the cecum. Typhlitis means inflammation of the cecum. Perityphlitis means around the cecum inflammation is there. So they were not able to pinpoint that the cause is in the appendix. They thought that there is inflammation around the cecum, and in this inflammatory process the appendix is swollen. That is what they presumed. That's what they used to call it as perityphlitis. FIDS, what he did was, he did surgeries for those acute right iliac fossa pains. And there he found that the appendix is very much swollen, inflamed. So he, after studying few cases like that, then he come to the conclusion that it is not perityphlitis, it is acute appendicitis. So what are the types of inflammation? The types of inflammation can be classified into two types, the catarrhal type and obstructive type. What will happen to the appendicitis, how it progresses? The appendicular inflammation can spread locally. Can spread locally. Local spread leads to local peritonitis. That means local parietal peritoneum will be inflamed. So whenever the appendix is inflamed, that causes inflammatory exudates. These inflammatory X-rays will collect in the right iliac fossa and causes the localized peritonitis. And if it is not treated, this localized peritonitis now will spread to the rest of the peritoneal cavity, producing generalized peritonitis. The second thing that can happen is localization. Localization means when the host defense is good or appendicular inflammation process is poor, then there will be localization. The surrounding structures will come and adhere there and it will form a mass. In some cases, there will be formation of an abscess. The third thing that can happen to appendicitis is resolution. If it is mild inflammation or if the host resistance is very good, the inflammation will subside on its own without any residue. Of course, this may cause little fibrosis of the appendix. So these features are seen in catarrhal appendicitis. In obstructive appendicitis, usually the spreading infection will be there. So in obstructive appendicitis, the spread of infection to the general peritoneal cavity occurs more frequently and more early. You can see here, this is the appendix, which is very much congested, shiny, edematous. This is the mesentery. So you can see the mesentery is very much swollen because it's become edematous. So edematous mesentery with edematous congested appendix. So this is catarrhal appendicitis. If the appendicitis is not tackled early, it can lead to this gangrene. You can see gangrene starting in the tip. Already I told you why the early gangrene occurs in the tip, because appendicular artery is there in the wall. Whenever the wall becomes turgid and stretched, the vessel will be thrombosed, producing this gangrenous patches here. Now let's study a few points about catarrhal appendicitis. There is inflammation and edema of the mucosa spreading to the muscle coat. So the disease starts first in the mucosa of the appendix. Later, the inflammation spreads to the muscle coat, and from there it spreads to the serous coat. From the serous coat, what will happen? It will spread to the surrounding structures. That means it produces local peritoneal infection. Then general peritonitis. Local peritonitis leads to general peritonitis. This is how the spread occurs. Method of spread by gradual transmural spread. Intramural edema causing occlusion of the terminal part of the appendicular artery. So when intramural, that means in the wall edema. Whenever the edema occurs in the wall, what will happen to the appendix? It gets swollen. It gets stretched. The appendicular artery runs like this in the wall. So it longitudinally runs. It is like this. It gives off branches. The branches come from the appendicular artery. They go around the appendix in a circumferential manner. Whenever the appendix is swollen and very much stretched, what will happen to the blood vessels? These blood vessels are also elongated because they are going like this circumferentially. So when they get elongated, their lumen becomes narrowed. So whenever their lumen becomes narrowed, the blood flow becomes reduced. And reduced blood flow along with surrounding inflammation produces vasculitis. This vasculitis causes thrombosis. Or even without thrombosis also, when the vessel is elongated, the diameter becomes reduced, and that can cause the decreased perfusion of the appendix, and it causes gangrene. So the inflammation from the catarrhal appendix can spread directly from the mucosa to the serous cords, or it is because of the gangrene at the tip of the appendix. So once perforation is there, there will be spreading peritonitis. So this is the intramural artery. So intramural artery becomes occluded, or its branches become occluded. What are the factors responsible for spreading of the infection? Number one, abuse of purgatives. What will happen? Usually the patient will have pain in the abdomen. So the patient says that he is having a lot of pain in the abdomen. So someone in the house will say, this is indigestion pain. People always feel that pain can come because of constipation. They call it as indigestion. So how to relieve indigestion? By purgation. So they give a purgative. So whenever purgative is given, there will be vigorous peristalsis of the whole bowel. So this peristalsis will cause spread of inflammatory exudates from right iliac fossa to whole of the peritoneal cavity. So that is how the peritoneal infection can spread. So the dictum is, whenever a patient is having acute pain abdomen, a purgative or laxative should not be administered. The other factor for spreading of infection is due to perforation of the appendix. So if the appendix perforates, all its contents will gush into the peritoneal cavity, producing the spreading peritonitis. Extremes of age, small children and elderly people, they are more prone for spreading of infection. Why so? The reason is, in small children, the greater momentum is not well developed. In any inflammation of the abdominal cavity, if some organ is inflamed, the appendix will go there and adhere there. So once the large fold of peritoneum or greater momentum adheres to that particular place which is inflamed, the inflammation will be contained in the leaves of the greater momentum. It won't go beyond the greater momentum. In children, this greater momentum is very small. So it cannot go up to the right iliac fossa and cover the appendix well. That is why appendicular inflammation exudates, they spread along the bowels and they spread to the other parts of the peritoneal cavity. Why in the elderly? In the elderly, the vessels are already sclerosed. A sclerosed vessel is more prone for thrombosis whenever there is vasculitis and for occlusion. So there are early chances of gangrene will be there in elderly people. Similarly, if the appendix is in pelvic position, because it is not in midst of the bowels, so it is more likely to spread its infection across the peritoneal cavity. The other factor is previous abdominal operations, which limit the mobility of the greater momentum, because greater momentum will be adherent to the scar, previous scar. So it is not mobile. So it cannot reach the right iliac fossa to enclose the appendix and to contain the infection. Actually, greater momentum is called as the policeman of the abdomen. So wherever there is inflammation, if there is gallbladder inflammation, it goes and covers it. Appendicular inflammation, it goes and covers it. If small liver tear is there, bleeding, so greater momentum will go and then cover there. So like that, wherever some inflammation is there, the momentum will go and adhere there. And the other factor for spreading of infection is decreased host resistance due to diabetes mellitus, HIV, or immunosuppressive therapy, like steroids or cancer chemotherapy patients. They are more vulnerable for spreading of the infection. Localization of the infection. When host resistance is good, the fibrinous exudate collects on the serous surface of the appendix. Because there is fibrinous exudate, that fibrinous exudate will cause gluing of the adjacent bowels to the appendix. And greater momentum also gets glued there. So whenever the appendix is being glued by surrounding organs, surrounding viscera, so the infection gets contained within this mass of adhesions. So this forms an appendicular mass. Sometimes there may be the pus in between the or within the mass. Then it's called the appendicular abscess. If host strength is good and inflammation is mild, there will be resolution. So you can see this is the acute catarrhal appendicitis. This is all these features are acute catarrhal appendicitis in various stages. You can see here there is development of gangrene at the tip. Here also you can see at the tip there is gangrene. Here whole thing is very much congested and became edematous. And here you can see the whole appendix is become gangrenous. So whenever the inflammation is severe and then where it is prolonged or delayed, this can happen. Obstructive appendicitis. So when the appendicitis occurs due to an obstruction in the appendix, then how it manifests? Let us see. This is a case of appendicitis. Up to here it is normal. You can see very much dilated appendix here. When I cut open this one, you can see this one. What is this? This is causing obstruction. Can you guess what it is? Actually, it is not a stone. Fecal matter is like a stone. This is called the fecalith. Yes, that's called the fecalith. So fecal concretion. From the cecum, some of the fecal matter enters into the appendix. And by the peristaltic activity of the appendix, all this fecal matter will be again propelled into the cecum. Sometimes what happens is, if there is some stasis of the fecal matter in the appendix, its water gets absorbed by the appendicular wall. So the fecal matter gets inspissated and it stays there. It won't get emptied for a long time. So then there will be deposition of the calcium salts. And the routine, regularly the epithelium will be debriding. So every 3 or 4 days, the epithelium denudes. A new epithelium occurs in the alimentary tract. So all this denuded epithelium also, debris also will collect in this mass. And this gets solidified. So this is called the fecalith. So this fecalith can cause obstruction to the lumen of the appendix and can cause an obstructive appendicitis like this. So this is the fecalith, just looking like a stone. So whenever there is an obstruction to the appendix, there will be distension of appendicular lumen distal to the obstruction. We have seen that in the previous photograph. This causes raised intramural tension. This causes gangrene of the appendicular wall. Whenever gangrene is there, it can perforate. And this produces peritonitis. So gangrene formation and perforation occurs, the sequence of events occur very early. In catarrhal appendicitis, it takes about 48 hours to develop gangrene. In obstructive appendicitis, it takes about 6 to 10 hours only to occur gangrene. So usually obstructive appendicitis manifests with generalized peritonitis because it's occurring early. So before the intestines come and glue there, before the momentum comes and wraps there, perforation occurs because of over distension. So whenever distension is more, there will be more chance of gangrene and perforation and leading to acute generalized peritonitis. You can see here, this is a case of obstructive appendicitis with the whole thing has become gangrenous. This is also the same thing. So catarrhal appendicitis, they can undergo resolution with fibrous at the tip. Sometimes it can result in mucocele. We already studied about mucocele in relation to gallbladder. What is the mucocele of gallbladder? Whenever there is an obstruction, the normal secretions of the mucous membrane, they cannot be emptied. So that is why distal to the obstruction, there will be distension. What is mucocele of mucocele? What is mucocele? We have studied about mucocele in relation to gallbladder. So tell me, what is mucocele? Very good. Collection of mucus in the gallbladder due to obstruction at the neck. It should specify that this is a aseptic collection. Aseptic mucoid collection in the gallbladder, that is mucocele of gallbladder. Similarly, aseptic mucoid material collection in the appendix is called the mucocele, and it is due to obstruction in the appendix. The catarrhal appendicitis can form appendicular mass. It can lead to appendicular abscess. It can have gangrene and perforation, of course, after 48 to 72 hours, and that may lead to generalized peritonitis. Obstructive appendicitis can cause gangrene early, peritonitis, rarely resolution, and rarely mass formation. So what did you understand here? Obstructive appendicitis is dangerous. It should be tackled early. It should be diagnosed early. So in the clinical features, please follow the clinical features and just see whether you can make out obstructive appendicitis by clinical features, so that you can act very fast to deal with the case. Otherwise, patients will go into generalized peritonitis. What is the problem with generalized peritonitis? We will study tomorrow or day after tomorrow. Peritonitis produces a lot of metabolic changes. It produces septicemia. It produces fluid electric disturbance. It produces toxemia. So many things will be there. So all these things we will discuss in the peritonitis topic. So generalized peritonitis will produce a lot of morbidity, and sometimes, if untreated, can lead to even mortality. So clinical features of acute appendicitis. Incidence: it is the commonest cause of acute surgical abdomen in young adults. Age: rare in infants and commonly seen in young adults. Relatively uncommon after middle age. It's more common in males. Clinical presentation: it varies. So clinical presentation is not the same in all the patients. It differs. So the presentation, why it differs? Because there are two types of inflammation: catarrhal inflammation and obstructive inflammation. So the catarrhal inflammation will manifest in one form, obstructive appendicitis will manifest in another form. Then clinical presentation varies depending on the position of the appendix. We have seen various positions. What is the commonest position? What is the commonest position of the appendix? What about others? Just I want to check whether you are following the class or not. What is the commonest position of the appendix? Okay, you are right. Only 4 have answered. This is right. That is retrocecal. So the other positions being pre-ileal, post-ileal, paracecal, subcecal, pelvic. So in any of the positions, appendix may be there. So in each position, it has a specific presentation or manifestation, and also depends upon the age of the patient and associated conditions like pregnancy. Now, features of catarrhal appendicitis. There may be general features of inflammation like that of any other acute inflammation, that is mild fever, malaise, tachycardia. So these are the features of general features we see. Then local features. So what we have seen in pathology, the inflammation starts in the mucous membrane. It gradually spreads to the muscle cord. From there it goes to the serous cord. At the serous cord there will be fibrinous exudates. So all these things to develop, it takes about 48 hours. So before the fibrinous exudate, what is happened to the peritoneum of the serous cord? It is inflamed. And this is in contact with the parietal peritoneum of the right iliac fossa. So it will be contiguous spread will be there to the parietal peritoneum. So there will be parietal peritonitis. So the local features depend upon this pathology. So symptoms are shifting pain, nausea, vomiting, signs, localized tenderness, guarding. Okay, what is this? Let us see. Shifting pain. Initially, there will be pain in the umbilical area. Later, the pain shifts to the right iliac fossa. Why there is pain in the umbilical area? You tell me. Already we studied about that. Yes. Appendix is a midgut organ. So the midgut pain will be always felt in the umbilical region. So patients will have pain in the umbilical region. Then once the inflammation spreads to the serous cord and causes localized peritonitis, the parietal peritoneum is inflamed. So because of the parietal peritoneal inflammation, there will be pain in the right iliac fossa. So the pain shifts from umbilical region to the right iliac fossa. So this takes about 6 to 8 hours. Then there may be feature of nausea and vomiting. Why nausea and vomiting? There will be associated reflex pylospasm. Because of the enteric nervous system, the stomach gathers information through efferent impulses from the enteric nervous system. So wherever there is inflammation, automatically the pylorus undergoes spasm. Why pylorus should undergo spasm? Some organ is inflamed, so it wants rest. So if the bowel is contracting normally, bowel is propelling the food normally, then the particular organ will suffer the most. So to prevent that suffering, what the pylorus will do is it undergoes contraction, spasm. So the food can't go down the duodenum. So there will be reverse peristalsis. So with this reverse peristalsis, patient gets nausea, and if there is food already in the stomach or patient has taken some food, means he will get vomiting. So stomach is like a big brother, protects the other viscera in the abdomen. So this reflex pylospasm, there is nausea and vomiting. So the symptoms are mainly shifting pain, nausea and vomiting. What the patient will vomit? He vomits what are the contents that are there in the stomach, that only he will vomit. What contents will be there? The food eaten by the patient before. So whatever he has eaten that, so it is vomited. So whenever there is pain in the abdomen with some vomiting of undigested foods, so naturally the patient feels that he is having some indigestion. So the treatment for indigestion in the patient's words is to have a laxative or a purgative. So patients will take purgative for that reason. On examination for this patient, you will notice tenderness. So due to local peritonitis and swollen and turgid appendix, tenderness is felt in the right iliac fossa with maximum point of tenderness at the McBurney's point. The base of the appendix is always constant. So that's why usually the tenderness is better elicited at the McBurney's point. Rebound tenderness, already I described about rebound tenderness. So in mild peritonitis, whenever you press your hand when the patient is taking expiration and suddenly leave it, so there will be bouncing of appendix against the parietal peritoneum and it produces a sudden severe pain. That is called rebound tenderness. So due to rubbing of the surface of the parietal peritoneum and the inflamed appendix, patient feels the pain. Cough test. Ask the patient to have a cough. So whenever the patient coughs, the abdominal wall moves. So the abdominal contents also move. So the inflamed appendix now moves against the parietal peritoneum, which is inflamed. So that produces pain again. So this is just like rebound tenderness. Guarding. What is guarding? Reflex spasm of the overlying muscles. Why there is guarding? Whenever there is parietal peritoneal irritation, the muscles overlying the inflamed parietal peritoneum will have the guarding. So what muscles will be there overlying the parietal peritoneum? Lower abdominal muscles usually. And this all depends upon the position of the appendix. For example, the appendix is in the pelvic position. So pelvic position means where it will be there? It will be falling over the lateral wall of the pelvic wall. So the lateral wall of the pelvis is having obturator internus muscle. So there will be contraction of the obturator internus muscle. Now if the appendix is in the retrocecal position and inflamed, so in front is cecum. So anterabdominal wall is not irritated first. What will be irritated? It is retrocecal, behind the cecum. So what structures are there behind the cecum? You can see here, this is the psoas major muscle. So you can see, this is the cecum and this is the appendix. If you take away the cecum, what structure is there? Behind it is this is iliacus muscle and this is the psoas major muscle. So psoas major muscle will be irritated. So it goes into spasm. So depending upon the position of the appendix, if the appendicular excitates irritates the anterior abdominal wall in the right iliac fossa, patients will have guarding of the right lower abdomen. If the appendix is in pelvic position like this, then it will irritate the obturator internus muscle that is situated here, and that fellow will have the obturator internus spasm. If the appendix is in retrocecal position, then it will irritate the psoas major muscle. So pelvic appendix irritates obturator internus. If of course, it is more medial, it can irritate the bladder or sometimes the rectum also. Retrocecal irritates the psoas major. Subcecal, pre-ileal or post-ileal irritates the anterabdominal wall, and the pre-ileal and post-ileal can irritate the ileum also. So guarding is due to reflex spasm of the overlying muscles. In paracecal, ileal and pelvic appendicitis, guarding is felt in the right iliac fossa. In retrocecal appendicitis, reflex spasm of the psoas muscle occur. So what is function of psoas major muscle? What is function of psoas major muscle? Psoas major muscle, it is situated on the front of the hip joint. Iliopsoas muscle, it is a powerful flexor of the thigh. It is a flexor, it is not an extensor. It is there on the anterior side. The muscle contracts. What will happen? The thigh will be flexed. It is not extended. How can it extend? If the muscle is there on the back, when it's contracted, it pulls it back. There will be extension. The muscle is on the front side. So when it contracts it. So there will be flexion only. There is not extension. It is not an abductor. It is a flexor. So that is why the muscle undergoes spasm. So patient will have pain on extension of the hip. So when you extend the hip, the muscle will be stretched. So the patient will get pain. This is called psoas sign. In pelvic appendicitis, the obturator internus muscle is spastic. So there will be pain on the internal rotation of the hip. So what is the function of the obturator internus? It is external rotation. So when you do the opposite thing, there will be stretching of the obturator muscle. So that is why patient will have pain. So this is called Cope's obturator test. So the progressive symptoms will be like this. First, there will be pain in umbilical area shifting to right iliac fossa in 6 to 8 hours. After the pain, patient gets anorexia, nausea, and vomiting. Then the patient will get pyrexia. So this is the order in which symptoms of acute appendicitis develop. Initially, there is pain. Later, few hours later, patient gets nausea, vomiting. Still later, patient gets pyrexia. So if any alteration is there, then it may not be due to appendicitis. Now let us study about the clinical features of obstructive appendicitis. Obstructive, so there will be colicky pain. So the colicky pain, where it is first felt? It is felt in the umbilical region. So severe colicky pain in the umbilical region suddenly. So we think of intestinal obstruction. So sometimes both will be confused. The other features are same as that of catarrhal appendicitis, but progresses more rapidly to general peritonitis. That means the nausea, the vomiting, the guarding, psoas sign, obturator sign, everything will be there for obstructive appendicitis also. But in obstructive appendicitis, we have seen that it will take about 6 to 8 hours for the pain to migrate from umbilical region to right iliac fossa. But in obstructive appendicitis, it will be matter of minutes or hours. Within 1 hour or 2 hours, you will find that pain is shifted to the right iliac fossa. So there will be rapid progression of the features. So the psoas test means, I repeat again, it is pain on extension of the hip. Extension means it is passive extension. It is not active extension. Passive extension means you ask the patient to keep his hip relaxed. You hold his thigh and you push it backwards. That means you have to extend his hip. That means you have to make his thigh go backwards. This is passive extension, I say. So similarly, obturator test also, it is rotating the thigh internally by the examiner, by the surgeon, not by the patient. So if the surgeon does it, it is passive rotation. If the patient does it, it is active rotation. So there will be pain on passive extension of the hip joint. It is not flexion, it is extension. Whenever passive it is extended, what will happen? For example, this is flexion, this is extension. When you hold the thigh, and push it like this backwards. This muscle will be stretched. So this is the psoas major muscle. So when you do it like this, the psoas major gets stretched. So they will get pain. Then atypical clinical presentation, pain of visceral or somatic may dominate without other element of pain. The shifting pain is present only in 40 to 60% of the individuals. The remaining patients, there is no shifting pain. They have either only umbilical pain or only the right iliac fossa pain. This occurs usually in retrocecal position because in retrocecal position, the inflammatory exudates, they do not escape to the anterior abdominal wall. So there is no pain in the right leg fossa. They have pain in the back. Then clinical presentation will vary according to the position. Retrocecal, localized pain and guarding in right leg fossa may be absent. There may be fixed flexion deformity of the hip and pain on extension of the hip. Sometimes there may be fixed flexion deformity. Usually, this is not seen in acute cases. This is seen mostly in the appendicular masses. So in the appendicular mass, I will describe about this fixed flexion deformity. I hope you know about testing the patient for fixed flexion deformity. Do you know what is fixed flexion deformity? You must have learned it in your orthopedics, TB hip joint. TB hip joint is one of the important questions for you in orthopedics. So there you must have learned about this particular topic, fixed flexion deformity. Do you know this or no? Fixed flexion deformity means, I will tell you here. Actually, whenever the psoas major is spastic, it contracts. What it contracts means what will happen? There will be flexion of the thigh. So when you look at the patient, with the patient who is having psoas spasm, you expect him to have the leg should be like this. This is flexion deformity. But you will never see it like that. Though there is psoas spasm, you will not see the patient to lie on the bed with his thigh elevated like this. Why? Because the weight of the limb will drag it down to the table. So the thigh will be like this. So when the muscle is spastic, when thigh is in lifted position, because of the gravity, when it pulled it down, then what will happen? The spine will compensate. The spine will undergo a curvature. So there will be increased lordosis of the spine. So this increased lordosis of the spine will compensate, and the patient will now keep the limb flat on the table. So when you examine the patient, you will see the limb to be flat on the table. So by looking at it, you will see that there is no psoas spasm. But before you think that, what you must see, you must place your hand behind the spine and see whether the gap is present or not. If a gap is there, that means there is lordosis of the spine. So then what you should do, you should hold the other limb, not the affected limb. You hold the left lower limb and flex it passively into the abdomen. You push it like this. So when you push this down like this, this curvature now becomes flat and straight. So once the spine is became straight, then automatically the limb rises to the position in which it should be there. So this is called Thomas fixed flexion deformity test. So this test is done to say whether the psoas major is contracted or not. So in retrocecal appendicitis, because of the irritation of the psoas major muscle, it can undergo spasm. The spasm is severe, patient can develop this fixed flexion deformity. This is how you elicit the fixed flexion deformity. In pelvic appendicitis, there may be strangling. So whenever there is irritation to the bladder, whenever bladder is irritated, what will happen? The bladder wall will be inflamed. So whenever the bladder wall is inflamed, what will happen? The detrusor muscle will undergo spasm. So whenever the detrusor muscle undergoes spasm, what will happen? The capacity of the bladder decreases. Even for small quantity of urine, there will be reflex hyperspastic contraction of the bladder muscle. So if, for example, unless a person gets 300 to 400 ml of urine in the bladder, that fellow doesn't get the sensation of urination. But when the bladder muscle is inflamed, even for 40 ml or 50 ml of urine, the patient gets the sensation of micturition. So the muscles will become hyperreflexia. So the patient goes to the bathroom every 5 or 10 minutes, but passes one small quantity of urine, and that will be accompanied by pain because there is contraction of the bladder muscle, and it is inflamed bladder muscle. Inflamed bladder muscle, whenever contracting, it produces a lot of pain. So that is called strangury. Strangury is intense, painful desire to micturate with passage of few drops or few ml of urine, sometimes blood stain. That is strangury. Okay, there is one more doubt from the students. Why the other limb looks longer in the upper image? Okay, there is shortening. Actually, this photograph is not a patient of appendicular mass. You can see here sinuses. These are sinuses around the hip. So it is a case of tuberculous arthritis of this hip with flexural flexion deformity and shortening of the limb. There is shortening of the limb. So why shortening of the limb occurs in tuberculosis of the hip? So you please read your orthopedics, you will understand. This is not related to the appendix. You are right, you have made a good observation that the normal limb is longer than the affected limb. So there is shortness of the affected limb. Okay, in pelvic appendicitis, there will be strangury. If rectum is irritated, there will be tenesmus. The same thing in rectum. Painful, intense desire to defecate, often passing mucus with blood staining. Tenderness may be absent in the right leg fossa, but may be present just above and to the right of the symphysis pubis. If you do a distal rectal examination or you do Cope's test, that is obturator interest test, then you will elicit tenderness. Pre-ileal or post-ileal acute appendicitis, there will be diarrhea due to irritation of the lower ileum. So we have only few symptoms and few signs, but they are quite variable. So that is why how to arrive at diagnosis. So there is a scoring method to arrive at diagnosis. That is called Alvarado scoring. Shifting pain, 1 score. You give score of 1. Anorexia 1. Nausea and vomiting 1. Signs. Tenderness 2. Rebound tenderness 1. Pyrexia 1. Leukocytosis 2. And shifting to left, there is more polymorphonuclear leukocytosis 1. Total score is more than 7. It is highly indicative of acute appendicitis. So this Alvarado has recorded the symptoms and signs in various people, a large section of people with appendicitis. And he has given the scoring, and he has studied and found that if it is more than 7, they will have surely acute appendicitis. Variation in clinical orientation due to age. Infants and children. Infants, there may not be complaint of pain, they will be only crying. So with crying, you cannot understand why they are crying. It may be because of cold, it may be because of earache. There is sometimes upper respiratory infection can cause otitis media. That may produce severe pain, and they will cry. There may be abdominal colic, there may be intestinal obstruction, there may be acute appendicitis, there may be fever with crying. So crying will many reasons. So it is very difficult to elicit. Diarrhea, because appendix is higher up, irritates the bowel loops. In adults, diarrhea occurs only in pre-ileal and post-ileal appendicitis, but in children and infants, diarrhea may be the early symptom. Pyrexia of less than 38.5 degrees centigrade. Early genital peritonitis can occur due to ill-developed greater momentum. Already I told you, in children there is less developed greater momentum, so they are more prone for genital peritonitis. Old people, the muscles are lack and reflexes are dull. Hence, guarding is minimal or absent, but tenderness is present. These people are prone for gangrene and early peritonitis due to atherosclerotic changes in the blood vessels of the appendix. The compromised hemodynamic system may lead to high mortality in old people. In pregnancy, the symptoms may vary. If you read any obstetrical book, you will find that appendix is displaced upwards due to growing uterus, and hence pain, tenderness, and guarding are felt in right lumbar region and more laterally. So this is what the obstetric books say. So because pregnant uterus is growing upwards, it pushes the appendix slightly to the outside, and also it lifts the appendix upwards. It pushes the appendix upwards. That's why the appendicular pain is felt not in the right iliac fossa, the appendicular pain is felt higher above. But in many of the patients, what is observed that pain is felt in one right lower quadrant in most of the cases. Because patient is having pregnancy, the bowels cannot be pushed upwards. And that too, the ascending colon and cecum, they are retroperitoneal, they are fixed structures. The fixed structures cannot be pushed upwards. Why the obstetric books say like that, we do not know. But the thing to remember in obstetrics is the inflammatory X rate may irritate the uterus. The inflammatory X rate may irritate the uterus and may cause miscarriage or preterm labor. The incidence is higher with the near-term and perforated appendicitis. Obese people, it is difficult to elicit tenderness and guarding because of large amount of fat in their abdominal wall. So it is difficult for us to elicit tenderness and guarding. If the patient develops genital peritonitis, what will happen? You just imagine and tell me what features will be there. The inflammation is not confined to the right iliac fossa. It has spread to the rest of the peritoneal cavity. So how the patient's symptoms will be there, tell me. Just imagine and tell me. Very good. Diffuse pain and guarding. Whole abdomen becomes like bone rigidity. Then, what will happen to the pulse rate and temperature? When only a small area of right iliac fossa is having inflammation, patient is having mild fever. But when the inflammation is spread, what will happen? Fever also increases. There will be more tachycardia. Yes. So rising pulse rate and rising temperature. Pyrexia higher grade, profuse frequent vomitings, and contains bile and intestinal juices. Tachycardia more than 120 per minute. There will be dehydration and toxemia producing oliguria. Local features: generalized tenderness with guarding, abdominal distension with absent bowel sounds because of reflex paralytic ileus. The reflex paralytic ileus produces this profuse, frequent vomiting with bile. Before general peritonitis, in appendicitis, patient has only vomiting once or twice of gastric contents. Once peritonitis sets in, then patients will get bile vomiting. So if appendicitis patient is getting bilious vomiting, it means his condition is becoming bad. The differential diagnosis. Anorexia is a mild grade of nausea. Vomiting is a mild grade of, nausea is a mild grade of vomiting. So anorexia, nausea, and vomiting are 3 grades. So differential diagnosis: upper abdomen diseases. In fact, acute appendicitis should be differentiated from all the acute abdominal conditions. We have studied almost about 80% of abdominal conditions. So you must be in a position to tell me, what are the acute upper abdominal conditions? Upper abdominal diseases manifesting with acute pain. Yes, very good. Peripheral epileptic ulcer. So here the pain first starts in the epigastrium or right hypochondric region. Well localized severe excruciating pain. In acute appendicitis, pain is dull, aching, and diffuse. Tenderness and guarding present over the upper abdomen initially in case of peripheral epileptic ulcer. But in acute appendicitis, it will be in the umbilical region, later in the right iliac fossa. In peripheral epileptic ulcer, sometimes there may be guarding in the right iliac fossa due to fluid passing along the right paracolic gutter. So we have seen this and I have explained this. In peripheral epileptic ulcer, sometimes there will be collection of exudate or fluid in the right iliac fossa, and so patient may manifest with features of acute appendicitis. Then acute cholecystitis, pain felt in the right hypochondric region with radius to the inferior angular right scapula and sometimes to the root of the neck. Acute pancreatitis, illimitable agony and guarding may be absent. Pain radius to the back, associated ileus plus shock may be present. Then this is the lower abdomen. Enterocolitis. Of course, post-ileal appendicitis also may manifest like enterocolitis. So there will be nausea, vomiting, and diarrhea. So in enterocolitis, before pain occurs, patient will have nausea and vomiting. It is associated with colicky pain. There is no well-localized tenderness. There is diffuse tenderness. There is no localized tenderness in the right iliac fossa like that in the enterocolitis. And there is no guarding. Amoebic typhlitis. There is acute amoebic infection of the cecum. Typhlitis means cecum. Cecal inflammation is called typhlitis. There is no shifting pain, no guarding. It may be associated with dysentery. Intestinal obstruction. colicky umbilical pain, no shifting pain, distension, vomiting with visible peristalsis will be seen, guarding only when there is strangulation. Then mesenteric lymphadenitis. This is the condition where, due to viral infection or Yersinia infection, the lymph nodes in the mesentery will be inflamed. This usually occurs in the children. There will be shifting tenderness. So this is contrast to shifting pain. Shifting pain is produced by acute appendicitis. Initially, the pain will be in the umbilical region. Later, pain shifts to the right iliac fossa. But in mesenteric lymphadenitis, what will happen? There is no shifting pain. But when you examine the patient in right iliac supine position, you will find tenderness in the right iliac fossa. Now, when you turn the patient to the left side, the mesentery along with the bowels will gravitate downwards. So, the pain, the tenderness will be felt not in the right iliac fossa, it will be felt in the umbilical region because the lymph nodes have moved towards the umbilicus. So, the tenderness will be there in the umbilical region. So, this is called shifting tenderness. So, shifting pain is present in acute appendicitis, shifting tenderness is present in mesenteric lymphadenitis. So, this is a PG entrance question, shifting tenderness. And there is no associated guarding as in acute appendicitis. Sometimes there may be associated cervical lymphadenitis may be present. Enteric perforation, it manifests during second or third week of enteric fever. Already we have discussed this. Pain is there in the right lower quadrant of the abdomen. There is fits of general peritonitis. Patient is severely toxic. Meckel's diverticulitis. Can you differentiate Meckel's diverticulitis from acute appendicitis or not? Is there any special feature to diagnose Meckel's diverticulitis? Tell me. No, Meckel's diverticulitis itself will produce acute pain without intussusception. It is just inflammation. Inflammation itself can cause acute pain. Because Meckel's diverticulum also is just like a diverticulum like appendix. It is also a midgut structure. So Meckel's diverticulitis also will produce pain in the umbilical region. Later, pain shifts to the right iliac fossa. On examination, there is same tenderness in the right iliac fossa with guarding in the right iliac fossa. So the symptoms of diverticulitis and appendicitis are the same. There is no difference. So clinically, it cannot be differentiated from acute appendicitis. But in some cases, in Meckel's diverticulitis, there may be maroon colored blood in the stools. Crohn's disease or terminal ileitis due to Yersinia infection. Here, diarrhea precedes pain. There is tenderness without guarding. A tender lump may be palpable in the right iliac fossa due to thickened ileum. Past history with weight loss is present in case of Crohn's disease. Rectus sheath hematoma. So this usually occurs acutely. For example, you think a patient is standing, he wants to lift a very heavy weight. So he bends, lifts the heavy weight and stands erect. So when he's moving like this from the bent position to the erect posture with tightly contracted abdominal muscles. So the muscles will be contracting while he is lifting. So in that case, what happens is there is a vessel, that is the inferior epigastric artery, which goes in the rectus sheath, that gets torn because of friction and produces a big hematoma behind the rectus abdominis muscle in the posterior rectus sheath. So the acute collection of blood there will produce severe pain. So sometimes you have differentiated from that condition. So there will be history of strenuous exercise, pain and mass of rectus abdominis muscle without gastrointestinal symptoms. Then disease of the pelvis, usually female patients has to be considered here. So female patients, genital organs are responsible, salpingitis. Pain is there on both sides of the pubic tubercles. Pyrexia of more than 38 degrees centigrade. There will be history of mucopollen discharge will be there for vagina. And on vaginal examination, you will find tenderness of the cervix and fornices. Ectopic pregnancy also produces pain. So tubal abortion or rupture may resemble appendicitis in the early stages. There is no evidence of shifting pain. History of menstrual period will be there. There is tender cervix. Features of hemoperitoneum may be seen. That is shoulder tip pain and local guarding. Twisted ovarian cyst, pain in the umbilical region or loin, tender mass felt in the fornix. Mittel smudge. Do you have any idea about this mittel smudge? Yes, very good. It is acute ovulation pain. So on 14th to 16th day, in between, the patient may ovulate. So when the ovarian follicle ruptures and releases the ovum outside, so there will be some release of fluid. Sometimes there will be capsule is thick and tough. So when it breaks open, sometimes there will be bleeding will be there from the ovarian follicle rupture. That blood will collect in the pelvis. So there will be sudden severe pain in the lower abdomen. And that pain will be there for a few hours, for 1 or 2 hours. Later subsides completely. So during the pain, when you examine, there will be severe pain, there will be tenderness, there will be guarding. So this ruptured ovarian follicle. So pain during 14th to 15th day of menstrual cycle may be associated with syncope sometimes because of severe pain. There may be bleeding PV and lower abdominal pain may be present. Symptoms subside within hours. Disease of retroperitoneum, urinary colic, pain from loin to groin. There is no guarding. Tenderness may be present in the course of the ureter. Dysuria may be present. Then right pyelonephritis. There will be fever with chills and rigor. Dysuria, loin pain with tenderness. Right testicular torsion. There will be pain in the scrotum, refer to the right iliac fossa. Scrotal examination reveals a tender, twisted cord and testis. Neurological, the herpes zoster. In the preherpetic stage, sometimes will produce severe burning pain in the right iliac fossa if it involves T10 and T11 dermatomes. Shifting pain is absent, guarding is absent, marked hyperesthesia of the affected dermatome is present. Of course, this is all the herpetic stages. In the preherpetic stage, when you examine, there is no finding except hyperesthesia. So especially in this region, if there is herpes zoster infection, so patient will complain of pain in the right iliac fossa. Acute radiculitis due to disease of the vertebral column like tuberculosis, disc prolapse, tumors of the vertebra, lumbar spondylosis, osteoporosis. Sometimes metabolic causes like porphyria crisis. It will produce abdominal and neurological symptoms with intermittent headaches of severe colicky pain in the lower abdomen, high colored urine turning deep orange when kept in sunlight, diabetic ketosis, diabetic crisis. Then purpura, there is Hennex colon purpura. This is a systemic vasculitis, which is autoimmune in nature. This produces a rash on extensor aspects with a normal bleeding time and platelets. So you will see this rash. So there will be vasculitis and there may be pain in the abdomen. So sometimes you will mistake this Hennex colon purpura to acute appendicitis. So this is about the differential diagnosis. So I will stop it here, and tomorrow let's continue this topic. Any doubts? Anyway, please read the differential diagnosis because we are covering almost all the emergency or acute abdominal conditions. So sometimes you will get an essay question. What are all the acute abdominal conditions? So you can write down the differential diagnosis of acute appendicitis. Any doubts, please? If you have no doubts, I will close this session. Okay, very good. Santi has a doubt. Why there is right shoulder pain in hemoperitoneum? Yes. Whenever there is hemoperitoneum, when you keep the patient in supine position, flat on the table, or with slightly foot end elevated, the blood in the peritoneum will gravitate to the diaphragm and irritate the diaphragm. So because the diaphragmatic irritation, diaphragm is innervated by phrenic nerve. So the pain is referred to the shoulder. So patient gets pain in the shoulder. Yes, very good. That's called Kerr sign. Any more doubts? Okay. If you have no more doubts, let's close this session. Wish you all good night. Thank you. See you tomorrow at the same time.